بسم الله الرحمن الرحيم. طبعا النهارده احنا بنرحب باستاذ الدكتور وسام اسماعيل، وبرحب بكل الضيوف اللي معانا، كل الحضور واللي هيسمعوا بعد كده التسجيل ان شاء الله من في مصر، من مصر ومن الدول العربيه الشقيقه. دكتور وسام، طبعا دي الحلقه رقم 8، مش كده يا دكتور وسام؟
متهيألي
رقم 8 يعني، فده اخلاص شديد جدا. النهارده دكتور وسام هتتناول موضوعين مهمين جدا، هتكمل بقيه الديبوزيتس، فهتتكلم عن الفايبريلي جلوميرولونيفرايتس اند اذرز، والجزء الثاني اعتقد الجزء الاكبر النهارده هو الدايابيتيك كيدني ديزيز. دكتور وسام طبعا غنيه عن التعريف، وهي ان شاء الله نبارك لها قريبا تبقى رئيسه مجموعه الاي اس ان الباثولوجي، وده حاجه طبعا شرف لمصر كلها. دكتور وسام اتفضلي.
شكرا.
اتفضلي.
انا النهارده ان شاء الله زي ما الدكتور حسين قال هنكمل what we consider deposits في الجلوميرولاي، or هندخل what is considered fibrillary deposits, or what's a fibril in general which can get deposited in a glomerulus. We have already discussed amyloid, and amyloid are the smallest fibrils, or of the group of the smallest fibrils randomly arranged. And the other known fibrils, very known fibrils, are fibrillary glomerulonephritis and IMMUNOTACTOID glomerulonephritis. And if you get into a larger, very large fibrils, like from 80 to 100 nanometers, then we can have a very rare entity known as collagenofibrotic GN. These are some of the names which is known. But actually, the term glomerular fibrillosis, or when you have fibrillar deposits in the glomeruli, refers to a more broad spectrum of renal and systemic diseases, where you will really need electron microscopy because it will have a major diagnostic importance in differentiating these types of fibrillosis. Not only that they cover a broad spectrum of renal diseases, we also have some controversy about the definitions of the terms introduced or the terms that we use. For example, Charles Alpers and Agnes Fogo, Rosenstock, and so on. And this is the majority, actually, I have to say, of renal pathologists follow these definitions, where fibrillary glomerulonephritis is characterized by compact fibrils less than 30 nanometers, while IMMUNOTACTOID glomerulopathy is characterized by microtubules, formation of microtubules more than 30 nanometers in diameter or equal to. I'll show you that this is not a very distinct way of classifying diseases because things are not that sharply clear. Then there you have also like Mel Schwartz and Corbett and other authors as well who regard the glomerular fibrilloses into a different way. They consider that IMMUNOTACTOID glomerulopathy is actually a common term, that it's common to find microtubules deposited in the glomeruli when you exclude, by very strict criteria, all hematological malignancies and paraproteinemias, when you exclude cryoglobulins, when you exclude systemic autoimmune diseases as lupus, and then you're left with these microtubules, then you can call IMMUNOTACTOID glomerulopathy. So it's not rather related to the size more than it's related to the structure of these fibrils. So the differential diagnosis of glomerular fibrillosis, which can include other things than fibrillary and IMMUNOTACTOID, will include amyloidosis, of course, CRYOGLOBULINEMIA, lupus nephritis, paraproteinemias with or without hematological malignancies. We have already discussed this. It can include Congo-red negative, non-immunoglobulin-derived glomerular fibrils as a rare disease, which is known as fibronectin glomerulopathy, and also can include increase in the native normal fibrillary constituents of the mesangium, because this is what you get normally in your glomerulus. So it can be a normal glomerulus, by the way. Diabetes is an example. Sclerosing glomeruli is an example. So not every fibril you would detect on EM is pathologic. That's number one. And number two, not every pathologic fibril is going to be related to a fibrillary GN or an IMMUNOTACTOID GN, because you have, as you can see, a long list of common diseases which can also cause the same, more or less the same appearances. Let me show you with pictures what we talk about. This is a normal glomerulus. And so normally your glomerular basement membrane is fibrillary, by the way, and it has fibrillars, but the difference is in the size. So fibrils in glomerular basement membranes are 4 nanometers only. So if they are more than 10 nanometers or more than 4 up to 10 nanometers, you might consider amyloid if you want. If they're more than that, you might consider other GN. In the matrix, the normal, in the mesangial matrix, the normal is 12 nanometer. And if you went back to the definitions, this is also the definition of amyloid, that it's up to 12 nanometers. And what's more than 12 nanometers, then can be something else. And this is also what you see in diabetes. So this is your normal glomerulus. Your normal glomerulus has fibrils in the glomerular basement membrane and has fibrils in the mesangial matrix with very much variation in size. Lupus. Lupus, when you ever read, tell you that it's characteristic and diagnostic for lupus when you find fingerprints. This is what's known as fingerprints of lupus glomerulonephritis. Again, microtubular structures, organized deposits, which can be found in almost all areas of the glomeruli. Let me tell you that fingerprints in lupus are present in only around 20% of patients. So it's nice when you find it, but it's not a criteria for diagnosis. And also let me tell you that up to 2% of patients, of lupus patients, can present with other looking fibrils. Like they can have microtubules like this, and they are huge in size, from 70 to 100 nanometer in diameter. They can have fibrils which simulate amyloid, and the fingerprint microtubular structure can even be misinterpreted as immunotactoid. This is fibronectin. As I said, this is an extremely rare type of glomerulopathy. And this fibronectin is a protein, and there are receptors present in our matrix. And this is how fibronectin deposits look like. And they are detected by immunohistochemistry. Because when you see this type of deposits, you cannot really swear that this is a fibronectin glomerulopathy. And there are only, I think, 1 or 2 centers in the world which has a specific stain for fibronectin, because they collect all of these rare cases. So the point is that when we have increased mesangial extracellular matrix or material in a glomerulus, we have 2 pathways to think of. Is this increased extracellular matrix immune globulin derived? Or an autoimmune process, or it's non-immune globulin derived? If it's an immune globulin derived, then we are looking at amyloidosis, fibrillary GN, immunotactoid glomerulopathy, or cryoglobulinemic glomerulonephritis. We know amyloidosis is going to be Congo red positive, and all the rest is going to be Congo red negative, including, of course, or going through also MIDD, which is also IG derived. So this is the site or one pathway where we have immunoglobulins or light chains or both of them deposited in the glomeruli and giving these different forms of fibrillary deposits and microtubular deposits. On the other pathway, you have the ones where you have an excessive collagen deposit or abnormal collagenosis, like in a collagenofibrotic glomerulopathy, or you have only 10 to 20 nanometers and random fibrils, like in diabetes. Diabetes is a fibrillary disease, by the way. Or you just have glomerular sclerosis, which again can include diabetes or other forms of nodular glomerulosclerosis. Point is, as you can see, all what you have as distinct factors, if you're just working on electron microscopy, is the size of the nanometers, stressing on the point that you do not diagnose by EM. It has all to be added together, the light, the immunohistochemistry, or the electron microscopy, even in diseases which are labeled to be diagnosed as EM. Otherwise, you're going to be lost in the sizes of the fibrils and how you differentiate between them. Between the major and common entities, let's exclude the very rare diseases, amyloidosis and fibrillary glomerulonephritis. This is easy to differentiate because amyloidosis has a bit of smaller fibrils. Again, they overlap. This one has 8 to 12 nanometers. This one is 12 to 20 nanometers. However, amyloidosis is Congo red positive. Fibrillary is Congo red negative. Extraglomerular affection is common in amyloidosis, is rare in fibrillary. You can have some tubular deposits, but not common. And it's not common also to have extrarenal deposits in fibrillary GN as it is common in amyloid. So you see the differentiation has to include everything, even the extrarenal manifestations. Between fibrillary and immunotactoid, it's the random fibrils, or as I'm going to show you, as far as we used to know till very recent, we only had this differentiation, which is random fibrils. These are 8 to 12 nanometers. These are larger ones and they are microtubules. However, both of them are IgG positive and C3 positive, and both of them are Congo red negative. So up till very recent, you could not differentiate them except by EM. And they were called collectively organized deposits, GN. Let's talk about fibrillary. Now, fibrillary GN was first described in 1977. The diagnosis of FGN can only be established by renal biopsy. So this is a renal biopsy diagnosis. You have no clinical features or any clinical suspicion to know whether your patient has a fibrillary glomerulonephritis or not. However, it's not a common glomerulonephritis so far. Again, I'm stressing. The reported incidence in native renal biopsies ranges from 0.6 to 1%. And as I said, it's considered within the range of organized deposits disease. According to the literature, the mean age of presentation in fibrillary GN is in the 6th decade. 2/3 are females. 70% has renal insufficiency at presentation with a mean serum creat of usually 2.9. Their mean 24-hour urinary protein is 5.7. 36% has full nephrotic syndrome. Up to 90% of them have hematuria. From 60 to 90%, so hematuria is a common finding. And fibrillary GN can be associated with systemic diseases. Reports vary from 7 to 27% of cases are associated with Hep C. 4 to 42% of cases are associated with monoclonal gammopathies. And this 42%, I'll show you where it comes from because this is a very high incidence. It's not common, by the way, for fibrillary to be within the monoclonal range. And 11% had autoimmune diseases, 24% can be in diabetics, and solid organ malignancies in 9%. So this is just your regular glomerulonephritis, which can be idiopathic or can be secondary to other systemic affection. Fibrillary GN under light microscopy can give you 5 patterns. It can give the mesangial pattern. This is the most common pattern, where you get mesangial proliferation / matrix increase, variable degrees, and this is usually the best prognosis of these patterns. These patients have the best prognosis, have the least serum creatinine at presentation, and the best GFR and the best follow-up prognosis. Then it can be membranoproliferative. It can give you a diffuse proliferative pattern actually with crescents, up to 30%. It can give you a membranous pattern. This is the least common pattern, but it can fibrillary can present as membranous, and it can present as a total global sclerosis where you can have more than 70% global sclerosis. And needless to say, this is the worst prognosis. If it presents with this pattern, you are already getting into end stage. And hence, fibrillary can be confused with a membranous GN, with a mesangial proliferation, with an MPGN. If you have focal proliferative, it's commonly confused with amyloidosis, and it can also be mistaken for a crescentic glomerulonephritis. And as we're going to discuss later in small vessel, when we come to take vascular diseases, why I don't like the term of crescentic GN. So this is one of the reasons. So fibrillary GN actually has a very variable light microscopy presentation. Your classic presentation, and whenever you will check up a fibrillary, this is what you will get. That this is your fibrillary GN with all of this mesangial matrix increase and expansion, a very characteristic pattern, and with not very florid mesangial proliferation. Main differential diagnosis are amyloid and diabetic glomerulosclerosis. This is an identical pattern. Again, this is with PES, and with PES, you can start seeing that the nature of the matrix itself, the mesangial matrix in fibrillary GN is different a bit from what you can see in diabetes or in amyloid. These cases are usually more PES positive than amyloidosis. So amyloid is very, very weak, PES reactive, but fibrillary can also be weakly PAS reactive, but usually they are more prominent when you stain them with PAS or with PAS staining. Again, this is a mesangial pattern, but in this patient, it had more mesangial proliferation than matrix increase. And here you can find that this patient were almost getting into sclerosis, but also with a mesangial pattern. The more dominant pattern in the mesangial pattern is the nodular sclerosis pattern. So we consider nodular sclerosis also as under the mesangial pattern, and hence, again, the main differential diagnosis, of course, is diabetic glomerulosclerosis and light chain disease or paraproteinemias. And you can see very nice nodular glomerulosclerosis, again, with a bit of a different matrix. Again, here, nodular sclerosis, and it's common to see a glomerulus with a prominent, just diffuse mesangial sclerosis, and in another glomerulus, you find the hypocellular nodules. This is an MPGN, your classic MPGN, and this patient turned to be fibrillary. This is the proliferative pattern. Usually it comes with crescents, as I said, and it can be up to 30%, and this is the membranous pattern, and it's quite uncommon to have fibrillary with membranous, and they are very difficult to diagnose just on light microscopy and immuno. And you can have the diffuse sclerosing pattern where you get mainly glomerulosclerosis, and in the rest of the glomeruli, as you see, matrix expansion. Again, the detection of these cases is not that straightforward because you really need to suspect it. Although what we usually knew that fibrillary glomerulonephritis is a diagnosis of electron microscopy, fibrillary is one, again, of the glomerulonephritis which has a characteristic and highly suggestive pattern on immuno, stimulating other GNs, for example, like I said, in dense deposit, where even though it's diagnosis of EM, you can still know it by its light microscopy and immuno findings. Same for fibrillary. It has a characteristic what's known as smudged deposits. These smudged deposits stain most intensely for IgG, and usually C3, kappa, and lambda, and sometimes also you get staining for C1q, plus or minus IgM, plus or minus IgA. So if you have an MPGN pattern with this type of, full house staining, then you would say that this is lupus. But you need to go back and see the type of the deposits to see whether these are smudged deposits or not, and to correlate it with the clinical findings. When it comes to the IgG subtype, most fibrillary GNs are actually positive for IgG4 and IgG1. IgG4 definitely typically exceeds that for IgG1, and you don't get IgG2 and IgG3. We have previously discussed the subtypes of IgG and membranous GN. So this is an IgG C3. This is a regular immune complex mediated glomerulonephritis with IgG C3, kappa, and lambda, and you can also find other immunoglobulins, and the IgG dominant subtype is IgG4. Now, this is what's meant by smudge deposits, and you can see the immunofluorescence, and I will also show it to you by immuno, and you feel that the deposits are not, you cannot really say that they are granular or linear. You just feel that they are مبطشين كده. This is what smudged actually means. You have these patches of deposits. And look, they are quite characteristic even by immunohistochemistry. In the mesangium, you can see this pattern of deposits. It's really different than any other deposits you can see. You have the background, and then you have these smudged deposits. This is IgG, and look at the higher power, look at the deposits. You can actually see them, and you can actually see that they are large, coarse deposits within the mesangium. This is a typical fibrillary GN by immuno. Look here again, this is a C3, nice, very nice smudged deposits all over the mesangium and the glomerular basement membranes. Again, C3 again, and you can see the type of deposits, patches and patches of these smudged deposits all over the mesangium. This is kappa, and fibrillary stains very strongly for kappa. And you can see that this are the deposits. They're present here. And it stains also for lambda, but with less intensity than kappa. this was one with a more of a membranous pattern, and you can see the IgG deposits all on the glomerular basement membrane. And this is IgG4, which is the subtype, and you can see very strong staining of the mesangial deposits by IgG4. As I said, till very recent, electron microscopy was the only way to diagnose fibrillary glomerulonephritis. What you're going to see are non-branching, randomly oriented fibrils with a mean diameter of 20 nanometers, but they can get up to 30, which are nearly always present in the mesangial matrix, in the lamina densa of the GBM. They can be subendothelial or they can be in the subepithelial regions. Anywhere in the glomerulus, you can find these fibrils. And as you can see here, this was one of our patients, and you can see the fibrillar deposits everywhere. And on a higher power, this is the glomerular basement membrane, and you can see the fibrils here. And this was Fibrillary GN. The three largest Fibrillary GN cohorts which were published were one in the Columbia University, where they had 61 patients. In Mayo Clinic, they included 84 patients, and in UNC, they included 42 patients. And then we have our own series, which in our Egyptian patients, and we have 36 patients. This is an incidence of 0.5%. When you compare, we have included only 4 years from 2015 to 2019, around 6,700 biopsies, and we had 36 cases. However, we don't know whether this is really a true incidence or not. Is this an underdiagnosed disease? Are we underestimating it because we don't do routinely electron microscopy for our patients? This is just a summary of the findings of the three major studies which were published in the literature. And I just want to show you some clinical points to compare it with our own population. Now, the mean age in the three studies were 57. All of their patients were more than 55. The second point was that they had a female predominance of 66%. Most of their 70% of their patients presented with renal insufficiency. 36% of them had full nephrotic syndrome. All of them presented with hematuria. 13% had hep C, because one study really had a large number of patients. And 11% presented with autoimmune disease. Again, 24% with diabetes, as I mentioned early in the introduction, 9% with solid organ malignancies, and 13% with dysproteinemia. The reason of this is the study of UNC, because they had 42% on their own. They had only 19 patients, 8 of them were dysproteinemic. So that's why they increased the total number of monoclonal gammopathies in relation to fibrillary GN. However, when you look at the Mayo Clinic study, where they had almost double the number of patients, which were 84, they only had 4%. And when you look at the Columbia study, they had 61 patients, they only had 15%. So this 42% was really high only in the UNC study, and I think this was a bit rather selective criteria. Now, this is our own study, or this is our own patients. We had 36 cases. These cases were all EM diagnosed, not the suspicious ones. The first difference is our mean age. Look at the mean age. It's 35 years old. It's not even close to 50. So the mean age of our patients with fibrillary GN is actually 35. The second major difference between us and the West is that we had a male predominance. 60% of our patients were male, although they had 66% of them were females. Second major difference was the renal insufficiency. They had reported 70% of their cases with renal insufficiency. We only had around 28%. But probably this can be explained by the fact that most of our patients were in the mesangial pattern. Most of our cases were actually in the mesangial or the nodular sclerosis pattern. And we already said that these patients have the best prognosis. So this is maybe why our patients had better figures in relation to the renal insufficiency. Hep C, we are the country of hepatitis C, and we had 6% of our cases only related to virus C. The rest were more or less the same like the reported incidences. We had 12% monoclonal restriction. The pathology patterns, as I mentioned, we had only one case with a proliferative GN, another case with crescents. However, 30 out of the 36 cases had a mesangial pattern, and out of them, 4 had a typical nodular glomerulosclerosis. Monoclonal restriction was mainly copper in 3 of the cases, and 1 case was a lambda. So we do have a different clinical presentation of our patients with fibrillary GN. Our patients are much younger. They tend to present more with the mesangial pattern, or maybe this is the pattern we detect. We could have undetected cases or presenting with crescents, or presenting as membranous, or presenting as other proliferative GN, and they are underdiagnosed. But the age is a very important point, as well as the male predominance versus the female predominance. But maybe when we have a larger cohort of patients, this ratio also will change. Let us take this case. This was a female patient, 38 years old. She's not a non-diabetic or hypertensive. She presented with nephrotic syndrome. Her proteinuria was 4 grams. Her serum creat was 1. Immune profile was negative. Virology markers were negative, and her C3 and C4 were known. So she presented with nephrotic proteinuria, and she was 38. She was actually referred to us, to our lab, with a diagnosis for amyloidosis. She was already diagnosed as amyloid, and she was referred to us for immunophenotype. However, the block referred contained minimal residual tissue. There were no glomeruli, so we advised for another biopsy. We could not phenotype on this biopsy. Now, this is her new biopsy with already the previous diagnosis of amyloid on her first biopsy. And you can see this is her H&E, and even on H&E, you can see she has minimal mesangial matrix increase. She could easily be amyloidosis. Again, however, on the PES, her mesangial matrix were actually slightly PES positive for what I would like for amyloid. And also, these deposits extended into the glomerular basement membranes, as you can see here, which is, again, okay for amyloidosis. Her silver, this is her silver stain, and you can see the mesangium nicely delineated in the silver, as well as the affected glomerular basement membranes. You can see that you have these deposits on the glomerular basement membranes. However, they were silver stained. They did not lack the silver deposits. This is her Congo red. This brings us to what we were saying last time, that an orange Congo red does not mean that you have amyloidosis. So this was her Congo red, and this was her Congo red under polarization. No amyloid. So this patient was not amyloidosis. This is her IgG, and as you can see, she had very strong dominant IgG deposits in the mesangium. However, it did not really look like the classic smudged pattern, but definitely she was very highly characteristic, highly suggestive of a fibrillary GN. So this is her C3, and her C3 even showed more of a membranous pattern rather than a mesangial pattern. But you can see it also at the mesangium, but almost all her basement membranes showed the C3 staining. And so we proceeded. So her IgA and IgM were negative. Kappa and lambda were equally weakly stained. So she had kappa and lambda, they were equally weakly stained. So she's not MIDD. She's not light chain deposition disease. She's not amyloidosis. She has IgG and C3 strongly positive, and kappa and lambda strongly positive in the mesangium and along her glomerular basement membranes. So we were only left with fibrillary. We did not have an EM biopsy. So we proceeded for DNA JB9. And I'm going to tell you what this is in a minute. Let me just show you how her DNA JB9 looked. Strongly positive. This is a marker, a new immunohistochemical marker. and you see it stained all the mesangium, and the segments of the glomerular basement membranes were positive and everything else was negative. What's DNA GB9? DNA GB9 is a very recently described marker for being a specific immunohistochemical marker for fibrillary glomerulonephritis. What is DNA GB9? This is an amino acid. It belongs to the heat shock proteins family, and it's important. It seems to be important in the recognition of misfolded proteins. It's present at low levels in the endoplasmic reticulum of most of our cell types, and in the normal kidney, it's present at very low levels in renal tubular epithelial cells, sometimes in the porocytes, sometimes in the mesangial and endothelial cell. DNA GB9 was detected in Fibrillary GN, represents the full length amino acid, meaning it's not mutated. It's the normal protein. The genetic sequencing did not reveal any pathogenic mutations. More importantly, it was not present in glomeruli with amyloidosis, any other form of glomerulonephritis, or normal controls. And it was shown that it co-localizes with IgG and the classic complement pathway in the glomeruli. We still need future research to know why is it so specific to fibrillary. Is it a direct cause, or is just an associated protein in Fibrillary GN? It's a marker with a 98% sensitivity and 99% specificity. So we don't need electron microscopy anymore to diagnose Fibrillary GN. You can just do DNA GB9. And we have done this when we got the marker. We went back to our fibrillary series, our Egyptian patients, and we stained all of them. We used cases of amyloidosis were used as controls, and 100% positive staining for DNA GB9, no stains in the controls. And as I said, all of these fibrillary cases were already documented as fibrillary by electron microscopy. So you can fairly say that DNA GB9 equals fibrillary glomerulonephritis. And this is a very reliable marker for the diagnosis in the absence of electron microscopy. Of course, this is really a huge jump in the diagnosis of this disease, and we will probably find more cases. The prognosis for Fibrillary GN is generally poor. It depends on the initial serum creatinine, the age of the patient, the level, the degree of the proteinuria, how much glomerulosclerosis you have, and of course the degree of interstitial fibrosis. We have no effective therapy to date. Most common form of treatment are steroids with or without a second agent, including cyclophosphamide or rituximab. Data are limited, although rituximab may offer benefit in patients with Fibrillary GN, particularly in patients with relatively normal baseline renal function. However, we don't have an optimal specific therapy for this disease. The importance for its recognition is that this is a recurrent disease post-transplant in up to 1/3 of cases, and the overall outcome for transplantation were similar actually in these recurrent cases to the overall transplant population. So it does not really affect the renal allograft survival, but it would be a very important cause of proteinuria. So to sum up, now that we have the DNA GB9, the diagnosis of Fibrillary GN might increase because we probably have been frequently missing cases, being hampered by the lack of biomarkers and the necessity of electron microscopy for diagnosis, which we know that it's not widely available. So the use of these markers whenever fibrillary is suspected may allow for detection of more cases. Probably you will find more fibrillary glomerulonephritis reported, and then it will not be such a rare disease, glomerulonephritis, and probably the incidence will increase now that we have the marker to look for it. So as I said, we are slowly moving from the era of electron microscopy into immunofluorescence, but we still have other entities which will require electron microscopy. Now, this was a 54-year-old female who presented also with a nephrotic range proteinuria. Her blood pressure was 140/75. She had lower limb edema 2+. She has arthralgia. Her family history was irrelevant. However, she had a significant past history for chronic lymphocytic leukemia, small cell lymphoma. she was sent for nephrological consultation, and I don't know why they were considering retox/steroids. They probably thought that she was monoclonal, which could be. Her creat was 0.9. Her urine analysis revealed 3+ protein, more than 6 grams per 24 hours protein, and a spot protein creat ratio of 6.9. She also had hematuria with positive dysmorphic red blood cells and occasional red blood cell costs in her urine examination. Serum albumin was 2.7, liver functions were normal, C3 and C4 were normal, oral histology was negative, but she tested positive for hepatitis B virus. So now we have a patient with nephrotic range proteinuria, more than 6 grams, with hematuria, with dysmorphic red blood cells, so it's definitely glomerular, and she is hepatitis B positive, antibodies, her creatinine is normal, and she has a history of CLL, small lymphocytic lymphoma. The common sense, of course, is to consider the first diagnosis, and that's why they considered rituximab and steroids, that this is a monoclonal gammopathy, which of course makes sense. This was her biopsy. This was a difficult case, actually. And this is a case I had while I was training. This is a very old case while I was training abroad. So it's mainly done by IF. There is no immunohistochemistry. Now she had all of these glomeruli. This is her trichrome. This is a blue trichrome. She had numerous foam cells in the interstitium. And some of the glomeruli showed a predominant membranous pattern. Other had these large thrombi inside of them. Let me show you. Again, this is her PES. And you can see very thick basement membranes. You have some nodules in the mesangium. And then you have intracapillary hyaline thrombi. So my first thought was that maybe this is a cryoglobulinemia, a type 1 essential cryoglobulinemia. Again, you see the extent of the hyaline thrombi and the mesangial matrix increase. Here it started to look more like a fibrillary GN rather than cryos, because it actually had absolutely no proliferation, no endothelial insult, nothing, just these plain thrombi. Again, very large, these hyaline pink thrombi, probably cryos, but nothing else. Now her immuno was strongly positive for IgG and C3, but did not have any form of a characteristic actually pattern in immuno. They did look a bit smudged though, but you cannot swear on them, and you did not have very strong mesangial staining. She stained for kappa 3 positive, and her lambda was completely negative. So she had a monoclonal immune complex mediated glomerulonephritis with thrombi, IgG, C3 positive, kappa positive. Does not look like cryoglobulins, look more like a mesangial pattern. And did not really look like a fibrillary. So as I said, this is a very old case. I'm not going to say how many years back. So of course we did not have any immunohistochemical markers or anything, but let me show you her EM. It was lovely. You can see that you have all of these dense mesangial and basement membrane deposits. And these deposits, even on this low power, looks like organized. Organized deposits means that they have a shape. They are not just indefinite deposits. They do have a shape. And on higher power, do you see the microtubules? It was actually an amazing case. Look here. This is typical classic what you call a microtubular structure, and this is immunotactoid glomerulonephritis. As you can see, they are present subepithelial, subendothelial, in the mesangium, everywhere. And on higher power, you can even see more the microtubules here and here. And I think, yes, you can see on a very high power the microtubules here as well on the glomerular basement membrane. So this is an immunotactoid glomerulopathy with monoclonal constriction, kappa type. Yes, induced by recurrence of her old CLL. So again, we moved from amyloid fibrillary to the microtubular, or to the larger form of fibrils, which is immunotactoid GN. Now, this is a more recent term than fibrillary GN. It was introduced in 1980 by Mel Schwartz and Lewis. Average reported age is 62 years old. Usually proteinuria can be up to nephrotic syndrome. Again, these patients can present with hematuria, but this is different than fibrillary in the fact that it is usually really associated with lymphoproliferative disease. This is number one. Number two, these patients does not have such a poor prognosis. They do not have a tendency to progress to end-stage renal disease, probably because their underlying problem is usually managed. It is characterized by microtubular structures, can be long and generally organized in parallel bundles. You have organized these microtubular structures measure 30 to 50 nanometer in width. They are negative for Congo red, and its main differential diagnosis is CRYOGLOBULINEMIA glomerulonephritis, because it gives you the same microtubular structure. And you can ask me, why didn't we diagnose this case as cryoglobulinemic, the case I just presented, although the patients actually did have some cryos in her glomeruli. Number one, her immunopattern is not for cryo. Cryos do not give you such strong staining. Two, cryos are not going to give you a predominant mesangial pattern of staining. Three, in cryos, you need at least IgM positivity as well, not only Congo red. You need these thrombi to really stain for IgM because they are IgM. And cryos are not going to be only, you're going to give you some weak lambda staining. They're not that monoclonal. This is, you don't always get it as nice. And the case I had was really exemplary, but in real life scenario, this is how immunotactoid looks like. So you can start guessing whether this is an immunotactoid glomerulonephritis or whether this is a cryoglobulinemia. And that's why some authors or some renal pathologists do not like to segregate it into a separate entity, except after they exclude everything else. And again, this is a high power of how the microtubules look like. The largest and the most recent series for immunotactoid glomerulopathy was published by Sameh Nasr in 2012. Patients, 100% of the patients presented by proteinuria, up to nephrotic syndrome in 70%, 50% only with renal insufficiency, and up to 80% with microhematuria. So you see clinical presentation almost the same like fibrillary GN. However, up to 50% of the patients were hypocomplementic. They had low C3, and more than 60% has a serum M spike. They already had a monoclonal band, and up to 45% of the patients have had evidence of hematological malignancies. The pattern of glomerular injury in immuno or EM in light microscopy, the dominant pattern was actually an MPGN pattern, followed by membranous. In comparison to fibrillary, here, as I said, in fibrillary, it's much less common to find a membranous pattern, while in immunotactoid, it's more common. Up to 30% of cases can present with a membranous pattern. And then you can have a proliferative GN up to 13%. Up to 70% of cases of immunotactoid, you're going to find light chain restriction. And of course, this is a diagnosis by EM. Again, in contrary to fibrillary, the immunofluorescence pattern is in no way diagnostic for immunotactoid. Not like fibrillary, when you can see these smudge deposits and know that this is what you're dealing with. Average time, they followed up their patients for around 48 months. 50% had remission, 33% had persistent renal dysfunction, and only 17% progressed to end-stage renal disease. And they have confirmed their findings with mass spectrometry. So when we come to consider a different diagnosis of diseases like fibrillary and immunotactoid by EM, then we have, as I mentioned in the first slides, and I'm revising again, that you will have to consider the collagen fibers, whether it's pathological or a chronic change, or you're just looking at a normal glomerulus. Bear this in mind. So when you have glomerulosclerosis, do not judge on collagen fibers. So, however, collagens are usually parallel, in parallel alignment. They are not randomly changed like fibrillary GNs. The periodicity is usually typical. They're often seen in expanded and sclerotic mesangium or in segmental areas with sclerosis, meaning that you're not going to find them subepithelial or subendothelial, but again, they should not be confused with amyloid or fibrillary GN, because both these conditions could be limited to the mesangium, and they do not have to have subepithelial or subendothelial deposits. More importantly is diabetes. Diabetes is a fibrillary disease. Diabetic fibrillosis, in diabetes, you get appearance of fibrils. Ultrastructurally, they are identical to fibrillary glomerulonephritis. They have the same size. They are 10 to 25 nanometers in diameter. They're randomly distributed and they are non-branching. This is your diabetes. But in diabetes, these fibrils, again, are only in the mesangium. You're not going to find them in the glomerular basement membrane. Diabetes is negative. It's not going to give you IgG and CAP and the deposits. Its IgG is linear, and this is only on IF. And it occurs in the setting of diabetic nodular glomerulosclerosis. Now, this is what I'm saying. When you come to have a differential diagnosis, everything has to be included. The light microscopy, the clinical of the patient, your immunostudies, and what you're seeing on EM. You cannot have just a separate electron microscopy diagnosis. This is diabetes. So you see in diabetic glomerulosclerosis, typically it looks just like fibrillary GN. This is your striated collagen 3. So this is a big source of, again, confusion if the pathologist was interpreting the electron microscopy is not the same one interpreting the light and the IF. This is number one, or they don't have a lot of experience. The differential diagnosis, another one which I care about, is cryoglobulins. I'm not going to get into details about cryos, but cryo is a very important issue for us here in Egypt. We all know, even with the DAAs, with the new DAAs, we still see patients with cryoglobulinemia post-treatment or with the newly discovered HCV patients. The important points I want you to know about cryo, that although this pattern, again, microtubular, you see it's similar to IMMUNOTACTOID, is nice to see, but in most series and in most patients, the deposits are amorphous. They look like your regular immune complex deposits. You do not get this microtubular deposits. Cryos, as you can see here, this is early electron microscopy findings. Early on, you will get your classic subendothelial deposits. And I want you to look careful. This is not even your classic MPGN deposits. They are rare deposits. This is why a pure cryoglobulinemia could be negative on immuno. You could not detect by immuno a lot of C3 or IgG/IgM, because you don't really early on get a lot of deposits. And you get the duplication of the basement membrane, and this is a very large, nice cryo occluding the capillary lumen. Later on, you're not going to see anything, just the duplication of the glomerular basement membrane, some resolved deposits, and even the changes in the GBM can mimic those of TMA. So my point is to tell you that cryoglobulinemia does not follow the regular form that you have in your mind, that it has to be with an MPGN and that all patients comes with membranoproliferative glomerulonephritis. No, cryoglobulinic is a standalone glomerulonephritis. And you can have a basement membrane duplication. You can have it with full-blown MPGN pattern. And you can have IgG and C3, but you can also have a very early stage with only proliferation, with minimal basement membrane duplication, and all what you're going to see is very sparse deposits, which you might not even detected by immuno. And the sentence of diagnosis of cryoglobulinic GN should only be made when organized deposits are present is nonsense. No. You don't have, you actually do not see these organized deposits on electron microscopy that common as you think. Cryo is a light microscopy diagnosis, full stop. This is how you diagnose cryoglobulinemia. You don't need electron microscopy to diagnose cryoglobulinemia, or you're never ever going to diagnose it. The other point is that the clinical information of no cryoglobulins found is no argument against the diagnosis of a cryo-GN, because for many hospitals, and that's worldwide, by the way, not only for us, the technique for the identification of cryos is too complicated. So cryo-negative means absolutely nothing, actually, to us as pathologists, because if I see that this is cryo, then this is cryo, even because, as I said, the test is highly, highly defective. So in conclusion, before we move on to diabetes, fibrillosis or fibrillary deposits in the glomeruli covers a broad spectrum. You have a broad spectrum of renal and systemic diseases which are characterized by glomerular, fibrillary, or microtubular deposits of different size, arrangement, localization, and composition. Some organized deposits are characteristic, like amyloid, like fingerprints in lupus, like fibrin, like mature collagen. Previously, it may have been a problem how to distinguish between fibrillary deposits and expanded fibrillary matrix in sclerosing glomeruli, for example, or in diabetes. But now this is solved by DNA JB9 if we are in doubt. And we still have an unclear delineation of immunoglobulin-derived organized deposits. In immunotactoid, in cryoglobulinemia, paraproteinemia can give you the same thing. The fingerprints you see in lupus are still also microtubules. So the sharp delineation of all of these entities is still not present. We call it immunotactoid because it's not anything else other than immunotactoid. Okay, do we have any questions up for this part?
Thank you very much, Professor Wesam. Really, cryoglobulinemia is very difficult to diagnose. Even in the serum, usually we have false negative results. So the clinical suspicion is important. And I'm happy that you explained even a lot of details about my pathological examination. We had an experience with Professor Ala Sabri because his PhD degree was in the HCV characterization, and he proved the presence of a fingerprint or viral-like particles within the electron microscope when he did his job at in Sheffield and I think Nottingham since a long time, and published his work in NEDT. Also, in the last year, we were aware by DNA GB9. This is why in the MD nephrology exam pathology station, we put a case similar in light microscope to MBGN, but the DNAB9 was present, was written, and I want to hear from the candidates that they knew Fibrillary Glomerulonephritis. So thanks for immunohistochemical staining. The DNAB9 is enough. We don't need electron microscope to diagnose Fibrillary Glomerulonephritis. Professor Dalat Bilal, تفضل.
Thank you, Wesam. It was great. بس هل أنت قلتي إن الأولي diagnosis of cryoglobulinemia is by hematoxylin eosine؟
لا، أنا قلت by light microscopy.
Light microscopy؟ This is the only way to diagnose it يعني؟ ما هو هيبقى
only way to diagnose it. لا، في فرق بين إن diagnosis is by light microscopy. That means that if by light microscopy it's cryoglobulins, then it's cryoglobulins. Even if the IF is weakly positive or negative, even if you cannot detect the cryo by EM, this is still cryoglobulinemia.
I think,
the only way to diagnose.
دكتورة دولت, I think the most يعني الفورم اللي احنا متعودين عليه ان احنا بنلاقي حاجه شكلها شكل الثرومباي ونعمل بالاميون هيستوكيميكال او اميون فلوريسنس نلاقي معظمها اي جي ام، فهي عشان كده الاي جي ام is an important for suspicion of cryoglobulinemia.
لا هي الكرايوز actually يعني it falls differential diagnosis. طبعا الكرايوز are IgM, of course are IgM kappa.
Yes.
انا بس ما رضيتش ادخل في كرايوجلوبولينيميا والا احنا مش هنخلص، لكن لكن هي
pattern and capillary right؟
مش شرط، ساعات بتبقى proliferative اكتر ما بتدي MPGN.
proliferative mesangial proliferative
لا
يعني؟
لا 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 diffuse proliferative.
diffuse proliferative اوكي.
يعني I mean the point
thrombi دي اللي is the clue يعني.
والسب اندوثيليال بالظبط. هي الكرايو is stage، كل ما بتقدم وكل ما العيان بيجي له recurrent episodes كل ما بتقلب اكتر MPGN، وكل ما بتلاقي الاي اف ديبوزيتس، وكل ما مش هتلاقي الاورجنايزد ديبوزيتس في الالكترون مايكروسكوبي، وهيبقوا امورفس اكتر، يعني انهم they disappear، وممكن ما تلاقيش خالص، ممكن تلاقيها ريزولفينج. وفي عيانين ما they don't go through the stage اصلا خالص، يعني بيقلبوا اصلا بميزانجيال proliferation وما يبقاش عندهم حتى MPGN pattern. يعني الكرايو is really a separate يعني it's a separate entity. مش عايزاكم to link it قوي to MPGN. Yes, we see it with MPGN of course, but what I mean is that yes, you can diagnose cryo without a frank MPGN.
Cryo is cryo. Cryo is cryo. Cryo is cryo. An MPGN may be without cryo.
Exactly.
But we are aware by the combination of cryo with MPGN because this is that we accustomed to see with hepatitis C. Yes. Yes. دكتورة دولة لو في حاجة كمان اتفضل.
لا شكرا.
اوكي.
دكتور طارق مدحت، دكتور طارق عباس لو عاوز يعلق.
مش سامعك.
بشكر الدكتورة وسام على التقديم الرائع. ما عنديش حاجة تعليق، بس استمتعت جدا يعني.
شكرا جزيلا دكتور طارق، شكرا جزيلا. خلاص عشان وقت دكتور وسام we can move to diabetic part.
Okay.
But I enjoyed the first part very much because it demarcates well the differential diagnosis and the algorithm you put in the beginning, immune or collagen. It's very nice, fascinating.
Thank you.
Okay.
Okay. This is a 49-year-old male with a history of diabetes, type 2 diabetes for more than 10 years. He came with hypertension and chronic kidney disease, baseline creatinine 1.8. أنا بس عايزة أقول إن الحالات اللي أنا مقدمها النهاردة حالات صعبة، يعني it's not your everyday cases، عشان بس الشباب ما يفتكروش إن ده الcommon scenario ولا البتاع، بس هم دول are يعني they are our cases، بس they're not يعني your everyday case.
We like these cases دكتورة وسام لأنه ساعات بيبقى clinical مش ماشي، وساعات بنعمل تريتمنت للبيشنت وما نلاقيش ريسبونس، بيبقى ساعتها لانه الدياجنوز حاجه ثانيه خالص. ويمكن حضرتك اشرت ان الفيبريلاري جلوميرولونيفرايتس، يعني انا بعد القراءات العديده هو اللاين اوف تريتمنت مش واضح قوي، الايفيدنس مش قوي، لكن in favor of the use of rituximab.
Yes, this is true. So as I said, ده كان male patient عنده diabetes بقاله 10 سنين، أكتر من 10 سنين، hypertensive chronic kidney disease. He was 49-year-old. His baseline creatinine was 1.8. We presented with progressive generalized edema during the last year and increased serum creatinine. العيان was diagnosed with malignancy, cancer head pancreas 6 months prior to referral, prior to his presentation. The patient received Gemzar weekly infusions, 28-day cycles for a total of 2 cycles. So this is a patient جاي لنا بhistory of malignancy, cancer head طبعا ما راحش في حته، history of chemotherapy 2 cycles, diabetes اكثر من 10 سنين، hypertensive, baseline creatinine 1.8 وجاي بسيرم كرياتينين بيعلى وprogressive generalized edema. His examination upon presentation, blood pressure was 160/90, had congested pulsating neck veins, bilateral pleural effusion, moderate ascites, and bilateral severe lower limb edema. So he's markedly proteinuric. Serum creatinine was 2.1 and was rising. Serum albumin was 0.8, was very, very low. What do you want else? PTH was 356, glycosylated hemoglobin 9.2. Urine protein creatinine ratio was 4.54. He had almost no pus cells or very few red blood cells. Hemoglobin 8.1. Of course, hemoglobin platelets and TLC were a bit on the low side, expected. Every ANA, anti-double-stranded DNA, ANCA were negative. C3 and C4 were normal. They have done serum protein electrophoresis, but without immunofixation. He had no monoclonal band. Virology for Hep C, B, and HIV were negative. Fundus examination showed no diabetic retinopathy, and sonography showed bilateral grade 1 normal-sized kidneys, moderate ascites, and his pancreatic head tumor, as I said, was still there. It was a large tumor. It's 7.5 by 4.5 centimeter. Any ideas? Okay, let me ask you a specific question. Now, is this patient's problem diabetes, or is it his chemotherapy, or is it his chemotherapy on top of diabetic nephropathy, or is it something else?
So we have cocktail of manifestations.
Yes.
We have fundus.
You have a cocktail of manifestations.
Yeah. Fundus is negative. And when we find no retinopathy, we suspect other pathology. دكتورة دولة عاوزة تتكلم، فهسيب الدكتورة دولة تتفضل. يا دكتورة دولة.
دكتور حسين أنا بس سامع بالعكس، يعني ممكن ممبر كمان يعني عنده solid tube أهو.
بالظبط. أنا قلت our others.
الأذرز دول بقى كتير.
ما كل حاجة.
هو العيان الحقيقة الديفرنشال دايجنوستس بتاعه is widely open، يعني هو يركب أي حاجة في أي حاجة يعني.
وبرضه في ستيجمات اوف كرونيك كدني ديزيز، البي تي اتش عالي والكرياتين عالي ولونج ستاندينج دايابيتس
وان كنترول دايابيتس اصلا، يعني جلايكوليت هيموجلوبين بتاعه 92، وبعدين كمان ادينا له كيمو وهيز اوريدي هايبرتنسيف. يعني العيان الحقيقه كان جاي لي بهيستوري يعني ظبط. اوكي let's look at his biopsy. Surprisingly enough, his biopsy showed what looks like diabetes. He had significant arterial hyalinosis, and as you can see, mesangial matrix increase, excessive hyalinosis, glomerular Bowman's capsules frayed and thickened like in diabetes, and you have thickened tubular basement membranes, nothing in the interstitium, some tubular injury maybe, which is okay, he's already on chemo, so nothing. Again, this is his glomerulus, this is a globally sclerosed glomerulus, and this is his glomerulus. However, I just did not feel so comfortable about his mesangium. It just looked too homogeneous. He had classic hyaline caps for diabetes, as I'm going to show you. So he definitely had diabetic nephropathy, no question about it. This is his PES, but his mesangium was strangely weakly PES positive. So of course I doubted amyloidosis. But then his Congo red was completely negative, as you can see. Yeah, no even red deposits or birefringence. And then I looked at his immuno, and this was his IgG. And it's not common to get, you should not in diabetes get a positive IgG, especially in the mesangium. And again, this IgG had a bit of smudged deposits. And what was strange about it is that you had clear areas, you see? So you had the deposits here, and this actually corresponded to the nodular sclerosis, and there were no deposits here. Again, you had deposits in some areas of the glomeruli, and the sclerotic nodules were negative. So we've done DNA JB9, and as you can see, very nice, yes, very nice staining, and also the staining was selective like the IgG, with the sclerotic nodules of the diabetes negative. And this was his DNA JB9. His kappa and lambda were negative, I mean not significant, they were both equally positive. And so his final diagnosis was a fibrillary GN associated with diabetic glomerulosclerosis. So you don't only get fibrillary GN on its own, you can get it as I've mentioned in association with other diseases, as well as, of course, as you all know, that diabetes can be associated with anything else. I'm going just to share the...
هتقفلي ده يا دكتور وسام.
طيب حاضر ثانية واحدة. Okay. Yes. Are we good?
Yes,
Okay.
very nice, very nice.
So we come to renal biopsy in diabetes. I want to know how many of you agree on this sentence. Renal damage in diabetics equals diabetic nephropathy?
Nowadays, we don't like the term diabetic nephropathy. We like diabetic kidney disease or non-diabetic pathology in a diabetic patient rather than diabetic nephropathy, because diabetic nephropathy is an old name that denotes the changes that accompanies diabetes. That's it. With the classic natural history of microalbuminuria or A2, and then proteinuria, then nephrotic with renal impairment, and at the end of the spectrum is renal failure. So this
So
is
I hope that we all agree that when you have that in diabetic patients, renal damage is not only related to diabetes. Let me put it this way. It's not only diabetic kidney.
And I'll give a comment at the end of your presentation regarding this point from the clinical point of view, because we changed our mind with the deal of diabetic in the last 5 years.
I hope so.
Okay.
So, renal biopsies actually help to classify renal disease in diabetics in 3 major groups associated with different prognostic features. The first one is diabetic nephropathy, your classic diabetic kidney disease. The second one is non-diabetic nephropathy. And the third one, which is more important, is associated non-diabetic disease on top of diabetic kidney disease, like the case we've just presented. So we think that non-diabetic kidney disease is generally believed that it's difficult, that it can be reversed. You cannot reverse diabetic nephropathy, but you can reverse the non-diabetic nephropathy. And in these patients, if you manage the non-diabetic nephropathy, then you're giving the patient a better chance towards his prognosis. Based on data published between 1983 and 2012, the prevalence of diabetic nephropathy complicating non-diabetic renal disease ranges between 3 and 45%. So you have up to 45%, according to the literature, incidence of non-diabetic renal disease. Then the patients develop diabetic nephropathy, because most of you think that patients develop diabetic nephropathy first and then they are liable to get non-diabetic renal disease. No, actually it's the other way around. Actually, patients would develop non-diabetic nephropathy first, or non-diabetic disease, kidney disease first, and then they are going to be complicated by the diabetic kidney disease, making their diagnosis and management even much more complicated. We have no guidelines for what we consider renal biopsy in diabetes. I know you have your own indications for renal biopsy in diabetes. I don't disagree with them. However, it is generally up to the personal evaluation of the nephrologist and his patient, whether he sees that this patient needs a biopsy or not. According to the Clinical Journal of American Society of Nephrology in 2013, and this was a dismal sentence, they were not happy with it. They were saying that nowadays, up to 25% of renal biopsies are done in patients with diabetes. Now, this is our patients, this is our patient population, and I want to show you that this is, where are the numbers? Yes. This is the total number of the native biopsies. Again, from 2014 to 2019, we had 7,740 biopsies. Only 837 of them were in diabetics. 95% of the patients were type 2 diabetes and 60% were males, and that's 11%. 11% of our biopsies are in diabetics. We're not even close to that 25%. This is our biopsy practice in Egypt. In relation to diabetic nephropathy, currently or diabetic kidney disease, that currently microalbuminuria is considered the earliest non-invasive marker you use to look for evidence of diabetic affection. There were other minimally invasive markers which were described, like serum circulating biomarkers like uric acid, vitamin D, tumor necrosis factors. You can try urinary microRNA profiling. They could be early indicators. You can try urine proteomics. Of course, these things are not currently available, and they are not bedside for the patients. Or cell-based assay of podocytes, maybe. These are the things which are described in the literature, and they are quite sophisticated. So what about renal biopsy? So you measure by microalbuminuria, whether it's considered the early non-invasive marker, and you have the renal biopsy, which is not that sophisticated. If you're going only to count on microalbuminuria, know that although most studies use the presence of microalbuminuria for the clinical...
دكتور وسام، هنسمح للدكتور اندرو عصام عاوز واضح ان عنده كومبيلينج كومنت. دكتور اندرو.
مساء الخير يا دكتور.
اهلا بحضرتك.
حضرتك اهلا بحضرتك يا دكتور.
اتفضل اتفضل.
اكوردنج لفكره ان ممكن اي دايبيتك نون دايبيتك نفروباثي يجي اون دايبيتك بيشنت، فهل لو لقيت مايكرو البومينوريا في عيان دايبيتك افضل اخد بايوبسي في الاول تحسبا ان يكون مش دايبيتك نفروباثي، ممكن يكون اي حاجه ثانيه؟ هل ده سجستد نعمله للبيشنت دول؟ شكرا.
لا طبعا، لا نيفر. لا مش ده الكلو ابدا.
لا مش ده.
خلينا بس نكمل ونقول حاجه تبع كلينيكال بوينت. اوكي.
No, we're saying if I'm looking for evidence of diabetic kidney disease in the patient, we use microalbuminuria because it's a non-invasive marker, and a renal biopsy is invasive. But if we come to consider how we utilize or the significance of the presence of microalbuminuria for the clinical onset of DN, in the absence of a histopathological evaluation, you see this is a very nice study, and it's relatively recent in 2016, and they've done an autopsy study. They had 168 patients, diabetics type 1 or 2, with or without clinical manifestation of renal disease. So not all of the 168 patients actually had established diabetic kidney disease. 106 of the 168 patients had histopathological changes in the kidney, characteristic of what we consider diabetic nephropathy. 20 of these patients had no clinical manifestations at all, had absolutely no microalbuminuria. The histopathological changes they have seen encompassed all classes of diabetic nephropathy except the sclerosing stage, except the last stage, because of course this is going to affect the renal function. And this study strongly suggested that symptoms of diabetic nephropathy most likely develop only when the extent and severity of the pathologic lesions exceeds the kidney's compensatory capacity. And this is an important point because we do know that serum creatinine is a bad marker for chronic changes, and seems that microalbuminuria as well is not a very sensitive marker for early diabetic changes. So these lesions were considered, is this a silent diabetic nephropathy? Because then these patients did not present with a microalbuminuria. The occasional observation of this histologically proven DN without albuminuria led to the widespread adoption of the term diabetic glomerulosclerosis instead of diabetic nephropathy by renal pathologists, as Dr. Hussein mentioned early in the talk. We don't use diabetic nephropathy, we use diabetic glomerulosclerosis in our diagnosis because irrelevant whether the patient has overt clinical manifestation or not, the lesion you're seeing is related to diabetic glomerulosclerosis. In our patient cohorts in Egyptian, the indication of biopsies in diabetic patients were almost 90% acute kidney injury, and followed by nephrotic range proteinuria, then subnephrotic range proteinuria in a small percentage of patients, and then few patients only had hematuria. Strangely enough, a clinical info you always seem to miss, or you just don't see it important, is the duration of diabetes. When we get a biopsy from diabetic patients, the duration of diabetes is not always mentioned. Out of 800, more than 800 biopsies, we have the duration of diabetes in only 20% of patients. So we have around 700 biopsies, 700 patients where the clinician did not bother to write the duration of diabetes. When you actually count on your diagnosis, and a major important part of why you took a biopsy is the duration of diabetes and how long this patient has diabetes. Only in our patient cohort, only 3.4% of the cases had diabetic retinopathy of the biopsies, which makes sense. Associated medical disease, they had 96% of patients had other associated diseases rather than diabetes. Of course, hypertension ranks the first thing, 65%. 18% had HCV. We had 9 patients with hepatitis B, and around 12% had other, like lupus, like rheumatoid arthritis, and other forms of medical disease. Now, diabetic glomerulosclerosis, or what you know as diabetic nephropathy, its diagnostic histopathological lesions, or the disease, actually covers almost all the compartments of the kidney. You have thickening of the glomerular basement membranes, you have mesangial expansion, nodular glomerulosclerosis, which is known as Clemstein-Wilson. You have what we call capsular drops, fibrin caps, capillary microaneurysms. You get also affections in the tubular basement membranes, and you get arteriolar hyalinosis. Now and because of this, in 2011, Travers have come up with a pathological classification of diabetic nephropathy, and this classification had 4 classes, where I'm going to describe now, and they have put criteria to what we should include in each class. The most important thing that in class 4, where you have advanced diabetic glomerulosclerosis, it's characterized by global glomerulosclerosis in more than 50% of the glomeruli, irrelevant which class you are in. So even if I have mild mesangial expansion and the patient is classified as 2A, and I have more than 50% glomerulosclerosis, then we are in advanced diabetic glomerulosclerosis. So again, these are not stages. Not all patients will go march from mesangial expansion to nodular sclerosis. Most of patients do that, but other patients don't. So you can have more than 50% diabetic glomerulosclerosis without nodular sclerosis, without your classic Clemstein-Wilson lesion. So the term advanced diabetic glomerulosclerosis means that you have more than 50% global glomerulosclerosis, irrelevant whether you have nodular sclerosis or you have only mild mesangial expansion. And it's even been described in class 1, where you get non-specific light microscopy changes. But then the diabetic glomerulosclerosis is going to be attributed to diabetes. Let's see. Class 1 is the class which represents the very early stage of diabetes, where you have a diabetic microangiopathy, which is mainly what causes you the microalbuminuria. And you have an increase of the thickness of the glomerular basement membrane. Now, this glomerular basement membrane thickening is an ultrastructural finding. So early diabetic nephropathy is an electron microscopy diagnosis. What are you going to get on light microscopy? No change, or only mild non-specific changes by light microscopy. And you don't have anything else. You don't have any form of mesangial increase, and you don't have any nodules. You don't have any sclerotic nodules. And if your immuno is negative, then, and you know that your patient is diabetic, then you would classify this as diabetic glomerulosclerosis or early diabetic glomerulopathy. But even though in the early classes you get changes which is specific for diabetes, you get the arteriolar hyalinosis, and you get the early thickening and fraying of the Bowman's capsule, and you get some mild thickening of the tubular basement membranes. By electron microscopy ultrastructure, you get a thickened, diffusely thickened glomerular basement membrane, no immune complex deposits, usually nice podocytes. You don't get into a podocytopathy at that stage, and hence your patient would present usually with subnephrotic range proteinuria. The patients have heavy proteinurias even at this stage, and with plus or minus hematuria. Class 2 is mesangial expansion, and this class is divided into two subclasses, 2A, which is mild, and 2B, which is severe. And the mild or severe mesangial expansion, where you have no glomerular nodules, this is measured by how much mesangium you have in relation to the size of the capillary to the adjacent capillary lumen. So you need, or that you need, it is not, the mesangial matrix does not increase the size, is not more than the space of two adjacent mesangial nuclei. I don't want to get into more very sophisticated histology details, but my point is to tell you that it's not a subjective measure. I just don't look at it and say, oh, it looks like mild, or maybe that it's moderate. No, there is some way. Yes, it's not really a very standardized or metric. It's not strictly metric method, but it's more or less semi-subjective. So we estimate either by the normal amount of mesangial matrix, which is supposed to be around the nuclei, or we compare it to the size of two adjacent capillary lumina, which is whatever is easier for the pathologist. And this is how we differentiate between mild and severe. We don't have a moderate criteria. Mild, if you have the expanded mesangial area less than 25%, severe if it's more than 25%. So usually they are marked. Again, you can see here extensive or marked mesangial matrix increase. Look at this one. I think you've seen enough of this pattern. Looks like amyloid, looks like fibrillary. It's diabetes. And I want to tell you that number one diagnosis is always diabetes, because this is the commonest disease, and what's common is common, and you have always to consider it. Yes, of course. And this is the golden rule in medicine. Don't stretch your mind to the less common entities before you exclude the common entity. Class 3 is simply nodular sclerosis, or what is known as Klumstein-Wilson. Now, you need for this class only one. If you have one convincing Klumstein-Wilson nodule, then you can classify it as class 3. And the biopsy does not have more than 50% global glomerulosclerosis, because if they are more than 50% global sclerosis, they are automatically class 4. So you get this nice nodule. The definition of Klumstein-Wilson is that you have a hypocellular nodule and the nuclei are arranged in a row surrounding the matrix. Again, here, hypocellular means that these nodules do not have mesangial nuclei, and that the nuclei are arranged in the periphery. Again, nodular glomerulosclerosis, significant nodular glomerulosclerosis, and with the nuclei arranged strongly PAS positive, which is a character of diabetes. And you can see here the hyalinosis and the nodule actually extending into the Bowman's capsule.
The capsular drop?
لا, I'll show you a capsular drop. A capsular drop does not, is not continuous with the glomerulus. Diabetes for me is a disease of hyalinosis. Whenever I see hyalinosis in the glomeruli, in the arteriole, within the sclerosed glomeruli, this signals diabetes. It's a highly hyalinotic disease. As I said, advanced diabetic glomerulosclerosis will be more than 50% global glomerulosclerosis, and you have clinical or pathological evidence that the sclerosis is attributable to diabetes. This is, of course, very important. Again, you see here, this is your classic diabetic glomerulosclerosis. Diabetes causes thickening and fraying of the Bowman's capsules. You feel that they are leaving each other. You get extensive hyalinosis. You get the nodular sclerosis, and usually interstitial fibrosis and highly thickened tubular basement membranes. So this is the flow chart of categorization. If you use the classification, I don't use it. I don't classify my diabetes biopsies according to this classification. And anyhow, this classification is undergoing revision these days, but I have no idea when will we have a new classification. Now, let me show you. This is a capsular drop. Do you see it, Dr. Hakim?
Yes, clear.
Yes, so you have this frayed Bowman's capsule, the mesangial matrix increase, and then I'll show you a better one. And this is a capsular drop. As you have hyaline caps, they look like caps, as if you have a cap casquetta يعني over the glomeruli formed of hyaline. You can get hyaline nodules, and you get extensive arteriolar hyalinosis. This is a capsular drop. Do you see it? Very nice hyaline capsular drop. And this is also a diabetic kidney. You don't get, there is hardly any mesangial expansion here, and the glomerulus is ischemic and slightly shrunken. But this is diabetic kidney disease, and you can see here very nice hyaline caps, extensive hyaline caps here again with the trichrome. You can see the hyalinosis and the interstitial. What was good about Trevor classification was that he included tubulointerstitial lesions and vascular lesions as well. So there was a score for the interstitial fibrosis, interstitial inflammation, whether we have interstitial inflammation or not, and whether we have vascular lesions or not, if you have arterial hyalinosis, or if you have arteriosclerosis. The scoring, as I explained earlier in previous talks, follows the same scoring system we use in all, more or less, in evaluation of the tubulointerstitium in all glomerular diseases. This is the changes in the tubular basement membranes. You get wrinkled, thickened tubular basement membranes. Again, diabetes. This is the arterial hyalinosis. And this is also, of course, the main differential diagnosis of diabetic glomerulosclerosis is light chain deposition disease. They are actually, they can be identical on light microscopy. Away from the glomeruli and not being very much glomerulocentric, and this is an important point I want to alert you of, is the presence of interstitial eosinophilic aggregates in diabetic biopsies. Now, because this is mistakenly interpreted as an allergic response or a drug-induced interstitial nephritis, or an interstitial nephritis with eosinophils in diabetic patients, and patients receive steroids or receive treatment and they get much worse, when actually this is a very common finding in diabetics. We don't know why diabetics get this form of interstitial eosinophilic aggregates, but we know that this is non-specific. And so they are more common in diabetic patients when you compare it to other types of glomerulopathy. And in diabetic patients, they are associated with the severity of the interstitial fibrosis. So the more interstitial fibrosis and tubular atrophy you have, the more incidence of eosinophils you're going to have in the interstitium, and they are not related with any prescribed medications or clinical history of allergy. It might suggest that these are associated with chronic tubulointerstitial injury. And this was a nice study done specifically on eosinophilic aggregates to resolve the debate in 2015. It's published in NDT, and they have found the same findings. This is eosinophils from biopsy, and this is how they look. Again, a very common finding and a very common debate, especially when you get a diabetic patient with an acute kidney injury with a history of non-steroidals, and then they want to build a whole diagnosis only on this eosinophilic aggregate, that this is interstitial nephritis induced by the non-steroidals. His AKI is induced by his non-steroidals, which can be simply an acute tubular injury, but it's not an interstitial nephritis with eosinophils, which requires intervention. You all know what can happen if you just freely gave steroids to diabetics. So this is an important point. Please be aware of it. Please be very careful, because as I said, this is quite a common finding in diabetic biopsies. We don't really consider it of significance. In our population, again, in our study, we had, out of the 837 biopsies, 63% of them had a diagnosis of diabetic nephropathy. And when we classified for the sake of publication, you can see that up to 70% of the cases were in class 3 and class 4. And this tells you that we biopsy our patients actually very late. We had only less than 30% of the cases where they had early diabetic glomerulopathy or they were just in class 2. So all patients had nodular sclerosis or advanced diabetic glomerulosclerosis at the time of biopsy, and 35% had non-diabetic renal disease. We're not 35% of the 63% patients with diabetic nephropathy. They had associated non-diabetic renal disease. When we come to discuss or consider structural functional relationship in diabetic nephropathy, we know that the main lesion is mesangial expansion. And when the mesangium expands, it restricts and distorts glomerular capillaries and diminishes the capillary filtration surface. So this is why early on, this is what you see. You have strong inverse correlations between all measures, mesangial expansion and GFR, urinary albumin excretion and hypertension. And that the progression models of diabetic nephropathy were mainly based on mesangial injury. But what I also would like to tell you that diabetics or diabetic kidney disease is also a form of podocytopathy. Remember when we discussed podocytopathy, and we said that with podocytes or diseases which can affect podocytes primarily, you can either have an increased number of podocytes or you can have a podocytopenia, like what eventually happens in FSGS. So diabetics also develop podocytopathy, which plays a crucial role in the progression of this disease. There is decrease in the podocyte number and broadening of food processes, which is associated with proteinuria and eventually get podocytopenia. And this is why you can get a heavily proteinuric patient with short duration of diabetes and with a light microscopy, which does not give you the classic nodular sclerotic pattern. And this is why some patients with, if you have two patients with the same class, like nodular sclerosis, one have heavy, remarkably heavy proteinuria, and the other has a non-nephrotic range proteinuria. So it's probably related whether this patient developed a podocytopathy or not. If they don't have, of course, a non-diabetic associated non-diabetic renal disease as membranous. What happens to the podocytes? This is a very recent article. Why do you get this podocytopathy, or why do you get podocyte injury with podocytopenia? Because you get some form of lipotoxicity of the podocytes. It's related to the metabolism of the lipids through sphingomyelinase-like phosphodiesterase receptors or ATP binding transporters. Without getting into too much sophisticated molecular details, the bottom point is that there is some malfunctioning within the receptors at the surface of the podocytes, which will lead to lipid accumulation. And this lipid accumulation will affect the mitochondria. And this is a mitochondrial-induced injury, which will eventually lead to podocyte injury and what's known as podocyte lipotoxicity. So this is in relation to diabetic kidney disease. What about non-diabetic nephropathy or associated non-diabetic disease on top of diabetic nephropathy? This is the list of associated non-diabetic disease on top of diabetic nephropathy. Simply anything and everything. A diabetic patient can develop any form of glomerular, vascular, or tubulointerstitial disease. You name it, and it can happen. So we don't have a specific set of glomerular diseases which occurs in diabetes. No. So a patient with diabetes is like a patient without diabetes. Both their kidneys are liable to develop any form of glomerulonephritis. What's the main difference? The main difference is that we also have the diabetes, the diabetic kidney disease, as a complicating factor. So they can develop amyloid, whether on top of diabetic glomerulosclerosis like in this patient, or only amyloidosis without evidence of diabetes, any type of amyloidosis. we see AA, ALECT, AL, all types of amyloidosis. So there is no specific direction for anything. Diabetes is not one of the cause. Yeah, it can cause secondary amyloid, of course, amyloid A, but patients get everything, get ALECT, as we have discussed, and of course, they also get AL, with or without diabetic kidney disease. Infections. We now know, as we've discussed also in infections, that diabetic patients are more prone to get infection-related glomerulonephritis, specifically the atypical one, which is staph-related, but you also get your regular streptococcal ones as well. And again, infection-related glomerulonephritis can occur on top of diabetic glomerulosclerosis or can occur alone. So you can get a diabetic patient who does not have diabetic kidney disease but presents with an infection-related GN. These ones are usually florid, quite acute, and commonly they are associated with crescents. This was an interesting case. This was a 48-year-old female who had diabetes 8 years, and she presented with, and was controlled, very properly controlled. She presented with a serum creatinine of around 2.1, proteinuria 4 grams, and low C3. So her nephrologist decided to, because this was not her baseline was lower than that, but I don't know how much was it. And this was actually her biopsy, and she was a bit perplexing because the common was to be that she has an infection, and she had this segmental endocapillary proliferation, but she also had this segmental subendothelial deposits. And also here, she had endocapillary hypercellularity, some thickening of the glomerular basement membranes, and her immuno showed only IgG and C3. So I told the nephrologist that she seems like an infection-related GN, but please check for lupus. And he was not very convinced, but he did check for lupus because he called me up 1 week later and told me her ANA and double-stranded DNA were on all her lupus markers. She is in lupus activity, and this patient had developed lupus, and she's been diabetic for 8 years. This is another female who is 32-year-old female, and she was a doctor, actually. She was a physician, and she's been only recently diabetic, 2 years duration, and she presented with a proteinuria 20 grams, and she was biopsied abroad, not in Egypt, and the conclusion of the biopsy report that this is an early diabetic nephropathy. And then she came here for consultation, and another biopsy was considered, but I asked to look first on the original slides. She had a single slide, but she had no block. And my first impression was also an early diabetic glomerulosclerosis. As you can see, her glomeruli looked always also normal. She had some arterial halinosis and some some Bowman's capsule changes. But the proteinuria with 20 grams did not fit, so we proceeded for EM, and typically enough, she had a classic minimal change disease, but we and the original pathologist were right. She also had early diabetic glomerulopathy. As you can see, her glomerular basement membrane was 1040. It was markedly thickened. So she had minimal change disease concurrently with her early diabetic glomerulopathy changes.
So this is superimposed minimal change on the early diabetic changes. Is there a difference?
She was only diagnosed 2 years.
Yeah.
Yes.
Is there a difference between podocytopathy and minimal change, or they are the same?
No, podocytopathy is not a lesion you see. Podocytopathy is a term to encompass all the problems you can see in podocytes. So minimal change falls
but if you find effacement of food process like this slide, fusion of all food process, this means minimal change and not the term podocytopathy.
Not the diabetic podocytopathy, yes. No, this means minimal change. What also signals for minimal change is a remarkable podocyte injury where you get this microvillus, cytoplasmic microvillus transformation. Okay. And the patient actually responded very well to treatment, which is not usually common in adult minimal change. We were not hopeful. This is a patient with ANCA vasculitis. Again, she was diabetic for more than 10 years, and she presented with ANCA vasculitis. this was also an interesting patient. Now, this is a patient who 56 years old, and he actually had recent diabetes, but we received the request with long-standing diabetes. Seriously, this is what the resident wrote, long-standing diabetes. He had a serum creatinine of 6 and a proteinuria 9 grams. And I kept looking at his biopsy and wondering, why is his serum creatinine 6? He did not have that much advanced interstitial fibrosis. And his glomeruli looked like he could have diabetic glomerular sclerosis. Although some of his glomeruli showed this PES positive deposits, which were odd, and sure enough, his kappa was actually very nicely stained all over his tubular basement membranes and his GBM. So actually, this patient did not have any diabetic glomerular sclerosis. He only had MIDD, and he would have been missed as a diagnosis of diabetic glomerular sclerosis, mainly because of the wrong info they had written mainly at that time, because it didn't even alert. If he's a recent diabetic, why is serum creatinine 6 and proteinuria 9 grams? At least the pathologist would have raised the question. This is how risky it is to be careless in writing clinical information to your pathologist. Do you see this? I don't know if you remember when we had the FSGS and we said that this is what we classically classify as a tip lesion. And this is, again, a diabetic patient with classic diabetic glomerular sclerosis and with a focal segmental glomerular sclerosis or a tip lesion. However, I want you just to remember that tip lesions can occur within the setting of heavy proteinuria, especially in diabetics. But this patient, again, did not have long duration of diabetes, and his proteinuria was really heavy. So an FSGS tip variant was a more probable diagnosis rather than non-specific finding of the tip lesion. And you can see always there is halitosis whenever you have diabetes. There were recently
we are accustomed, Dr. Wesam, we are accustomed to both a MCQ question regarding the pathological change in diabetic patient, which is more specific. And the answer is usually halitosis of the vessels. Is it right or wrong?
Yes, it is. It is. Some pathologists, some big pathologists like Kranicki, for example, like Helmut, it says simply, if there is no halitosis, there is no diabetes. Full stop. So don't even consider to diagnose a diabetes if you don't have halitosis in the biopsy. But I want to also alert that this could be tricky. In order to confirm that you don't have halitosis, you have to look at a lot of serials, look at all the arterioles, because sometimes you can get
sampling.
the halitosis.
Yes,
on later sections, and you can get mild halitosis. But I also agree. I would consider 10 times a diagnosis of any form of diabetic kidney disease if I don't have halitosis.
Okay.
So yes, I agree. As I said a few years back, there was a report describing collapsing glomerulopathy, which is superimposed on diabetic nephropathy, and that it gives insights into etiology of an under-recognized severe pattern of glomerular injury. Now, this is collapsing glomerulopathy. Remember when we discussed collapsing FSGS, and we said that we could have segmental collapse of the capillary loops, and we have florid epithelial cell hyperplasia, and that we maybe should separate collapsing glomerulopathy from FSGS. This is another evidence of it. Again, this is collapsing glomerulopathy. This is typical diabetic glomerular sclerosis, and you get all of this florid epithelial cell hyperplasia, and this is not a crescent, but it can be easily missed or misdiagnosed as a crescent, and I can't blame them. It's really difficult. Now, what happens, or what could be the possible pathogenesis? That you get a patient with hyperglycemia or insulin resistance, and then you have the usual pathway where you get hyperfiltration, glomerulomegaly, extracellular matrix, then you get diabetic nephropathy, then you have increased vascular endothelial growth factor, podocyte hypertrophy, you get podocyte denudation and podocytopenia, and you get typical diabetic glomerulopathy, which is from classes 1 to 4, and you start having a classic patient with slowly progressing proteinuria and renal failure. So this is 90% of your patients. But some patients actually have the predominant arm is in their microvascular disease. So they get dominantly microvascular disease, then they get vascular sclerosis and hyalinosis. They develop also diabetic nephropathy, but they can also develop severe glomerular ischemia, and the podocytes would undergo dedifferentiation instead of podocytopenia, and then they are going to be hyperplastic. So if we say that the classic podocytopathy, which can occur in diabetic nephropathy, is a decreased number of podocytes, if you consider this other pathogenesis, then you're going to get a proliferating podocytes and an increased number of podocytes. So you will end up having collapsing glomerulopathy on diabetic glomerulopathy, and these patients are going to have rapidly progressive course, heavy or new onset proteinuria, and renal failure. Now, what's interesting in this study, relative whether this pathogenesis is probably right or not, or whether these patients are common or not, but this follows the same concept we've discussed before, that we have a collapsing glomerulopathy in severe ischemic insult. And any severe ischemic insult can give you collapsing glomerulopathy. So always bear this in mind. This is not always your primary FSGS. Clinically, the patient will present with the same presentation, sort of acute nephrotic syndrome and acute renal failure. But these patients have severe ischemic insult rather than they have an underlying FSGS. And diabetes can cause severe ischemic insult. Non-diabetic renal disease in general is known to be prevalent in patients with type 2 diabetes, but we have a number of studies which suggested that diabetic renal disease may have a better prognosis than classical diabetic nephropathy. So if you detected diabetic renal, non-diabetic renal disease early on, you can deal with it because these patients could be cured or they could be managed and controlled, and then the prognosis is going to be better. However, these studies have not considered whether the biopsy was undertaken because of an acute deterioration in renal function or because of clinical features which were atypical of diabetic nephropathy, meaning that the indication of the biopsy would make a difference if you want to evaluate whether these patients have the non-diabetic renal disease, have a better prognosis or not. So timing of the biopsy is extremely important. You keep waiting and waiting and waiting, and then by the time, usually as I've shown you in our series, that the patients with non-diabetic renal disease or either already advanced, and I've shown you that out of up to 90% of our biopsies are because of acute kidney injury, and which is probably caused by a non-diabetic renal disease, whether it's superimposed on diabetic renal disease or alone, or without diabetic kidney disease. And all of these studies which tell you that these patients could have a better prognosis, or your classic diabetic glomerular sclerosis can have a better prognosis, you don't know, because at the end of the day, we never biopsy our patients early enough. Timing of the biopsy makes a lot of difference. This is a study where they had 263 patients, 263 biopsies with type 2 diabetes between 2002 and 2008. And they had 36% of their patients had diabetic nephropathy alone, 37% had both diabetic nephropathy and non-diabetic renal disease mixed, and up to 27% had non-diabetic renal disease alone. Diabetic nephropathy in their cohort correlated with the duration of the biopsy. So the more you delay the biopsy, the more chance that you're going to have diabetic kidney disease in the biopsy, plus or minus non-diabetic renal disease. So actually, diabetic renal disease is a time-dependent process. Non-diabetic renal disease remained common finding even in patients with long-term diabetes. So the point is that with the duration of the disease and the duration of the biopsy, the longer it is and the longer the patient is diabetic, the more chance you're going to find diabetic related changes in the biopsy. However, the duration of diabetes is irrelevant to the development of non-diabetic renal disease. So yes, your patient can present early on with non-diabetic renal disease, few months or few days post his diagnosis of diabetes. That does not have to be diabetes. And they have shown that patients with poor, actually patients who had acute kidney injury had a poor prognosis. This is our own patient cohort. These are 837 biopsies, and you can see all form of diagnoses in of non-diabetic renal disease, ranging from thrombotic microangiopathy. We had one case of C3 glomerulonephritis. We had around more than 60 cases of FSGS. You had a good percentage of patients with amyloidosis. Not much, almost close to the number of patients with membranous, because you always think that if the patient have a non-diabetic renal disease, then it's going to be membranous. No, see, membranous and amyloidosis were almost alike, and they were followed by light chain cast nephropathy. The CRYOs, of course, were in the HCV patients cohort. These were patients who had both amyloidosis and cast nephropathy. These were MPGN without CRYO, and so on. But the longest two columns were actually the infection ones. This is infection-related glomerulonephritis, and this is acute tubular injury. So at the end of the day, acute tubular injury were the commonest cause, which was noted in the biopsies of these patients, because, as I said, it corresponded to the indication of the biopsy, which was acute kidney injury. But everything else was seen. So finally, is diabetic nephropathy going to be the new normal renal biopsy finding in diabetic patients with other superimposed disease? With all of this evidence we've been discussing and all with what we're saying, then it should not be the only diagnosis. It should be a diagnosis of exclusion. So when we have a biopsy in a diabetic patient, we should expect to see diabetic kidney disease and start looking for non-diabetic kidney disease as well. So is it time to consider more regular or more routine kidney biopsy in diabetic patients, and not just wait and consider that what's happening with the kidney is diabetic related kidney disease? Because diabetic related kidney disease takes time to develop. So what's going on with your patient is probably non-diabetic related. It could be diabetic related, but it could also be non-diabetic related. The problems that when you perform biopsies, they are only performed when clinical course is not typical for what you consider diabetic related kidney disease. Biopsies do not represent the full pathological range of diabetic nephropathy in type 2 diabetic patients. We don't know, because we don't have that much biopsies in type 2. So there could be some pathologies we are missing in diabetic nephropathy, which we don't know about. The biopsies only represent patients with a typical clinical course, so it's expected to find all sorts of findings within this biopsy. Again, it does not reflect the reality, and there could be a wide range of non-diabetic renal disease which is missed. And bear in mind that when a patient develops non-diabetic renal disease and it gets complicated with the diabetic renal disease, then it's really going to be very difficult to detect it. It's not always that easy to know that the patient previously had a membranous nephropathy, previously had a fibrillary GN, previously had amyloidosis, and then he had diabetic glomerulosclerosis superimposed on it. So finally, pathological renal damage is hard to predict only with clinical and laboratory findings in diabetic patients. And unfortunately, patients with non-diabetic renal disease are often designated as having diabetic nephropathy because of the overlapping features of both glomerulopathies. Then you cannot know. Histology is really necessary to characterize different glomerular diseases originating from several non-specific clinical presentations. And we don't even have lack of study. We don't have enough studies in the literature telling us how should we approach the universal use of kidney biopsy in diabetic patients. But we need to work on our level of confidence to perform more routine kidney biopsies in patients with diabetes, and we definitely need more larger and more significant trials than what we already have. in diabetic patients, not only management trials or clinical or treatment trials or glucose control trials. We need trials related to the changes we see in diabetes, because you might be surprised that we don't actually know anything. And remember that in spite of everything, still the renal biopsy is the gold standard for diagnosis of diabetic renal kidney disease as well as non-diabetic kidney disease. Thank you.
Professor Wesam, for this excellent presentation as usual. يعني ما فيش كلام يوفي حقك يعني يا دكتور وسام، لكن اسمحي لي بس يعني هدي بعض التاتش كلينيكال. احنا كنا زمان بقى ريزيستنج تماما عمل بايوبسي في دايابيتك بيشنت بقوه يعني. لكن بقى في موف شويه توارد البايوبسيز. انا اي كانوت سي توداي ان احنا هنعمل روتين بايوبسيز للدايابيتك. نيفر اي سي ذس، لانه زي ما حضرتك قلت في البروبلمز جزء من الهاي برسنتج اوف نون دايابيتك كيدني ديزيز ان دايابيتك بيشنت جاي بسلكشن بايس، لان احنا بنعمل بايوبسي للناس اللي فيهم كلينيكال سسبشن اوف نون دايابيتك كيدني ديزيز. لكن برضه ما نبقاش الثريشولد البايوبسي نبقى ريزيستنج. وي شودنت ريزيست بايوبسي whenever we feel ان هي تغير اللاين اوف تريتمنت. فعلشان كده لو اتعمل بايوبسي روتين مش غلط، حتى ممكن يدينا بروجنوستيك فاكتورز. يعني لما الاقي جلوبال سكلروزس، لما الاقي الكرونيستي موجوده ببقى حتى بروجنوستيك. وطبعا وجود الدايابيتك نفروباثي او الدايابيتك جلوميرولوسكليروزس الكلاسيك ده بور بروجنوزس للرينال سرفايفل. لكن the presence of non-diabetic renal disease او حتى combination non-diabetic مع diabetic ده اهدى شويه من البيور diabetic glomerulosclerosis. لو عملت بايوبسي كله ما هوش رونج قوي، لكن ما ننساش ان البايوبسي انفيزيف وممكن ما تغيرش اللاين اوف تريتمنت. فبرضه الوايز ابروتش مطلوب، لا ابقى ريجيد وما اعملش بايوبسي ولا ابقى بعملها روتين. وعندنا انديكيشنز. الانديكيشنز كان زمان الميكروسكوبيك هيماتوريا بنقول عليها، يعني واحد دايابيتك وعنده ميكروسكوبيك هيماتوريا شيلناها دلوقتي من الكلاسيك انديكيشن، لانه وجود الميكروسكوبيك هيماتوريا ده ممكن يبقى في 50% من الدايابيتك بيشنتس. لكن الماكروسكوبيك هيماتوريا يعني العيان اللي جاي يقول لون البول محمر اعمل له بايوبسي. الحاجه الثانيه لو انا عندي اكيوت كدني انجري ما حدش بيختلف، البايوبسي بتتعمل. لو عندي نيفروتيك سيندروم with persistent normal creatinine ده مش الناتشرال هيستوري اوف diabetic patient، ده هعمل بايوبسي. absence of retinopathy بيخليني اعمل بايوبسي. في ستيجماتا اوف سيستميك ديزيز زي اللوبس زي ما حضرتك اشرت كده، يعني لو انا عندي diabetic patient وعنده كلاسيك ريتينوباثي وجاي لي بانتي نيوكلير انتي بودي بوزيتيف وفي سوبر امبوزد اكوت كيدني انجري او كلام زي كده او اكتيفيتي، انا هعمل بايوبسي لان ده لوبس بيشنت. فيبقى اذا اللي وصلنا له دلوقتي ان الثريشولد العمل البايوبسي قل عن زمان، لكن ما وصلش ان نعمل روتين بايوبسي لكل الحالات. هاجي للنقطه الاخيره قبل ما اسيب حضرتك تعلقي، انه في سايلنت نفروباثي موجود. الجماعه اللي اتعملت قبل كده في اوتوبسي، يمكن الاستاذ اللي حضرتك اشرت اليها ما اعرفش ده بتاع الاوتوبسي ولا لا، بس اتعملت السنه اللي فاتت في اليابانيين، عملوا كوهورت كبير جدا وطلعوا الالبومينوريك والنون البومينوريك الاثنين فيهم باثولوجي، وكلاس 3 وكلاس 4 موجوده في الاثنين. طبعا النسب بتبقى اكتر
هي دي الاستادي.
تمام. والنقطه المهمه انه لغايه دلوقتي ما فيش بايو ماركرز جيده ان هي تديني فكره. فعلشان كده البايوبسي is an essential tool ان انا اعرف المورفولوجي وبريدكت البروجنوزس وكان بيك اب النون دايابيتيك كيدني ديزيز اللي ممكن يحتاج سبيسيفيك تريتمنت. ويمكن حضرتك اشرت الى كل تقريبا الكاتيجوريز اللي ممكن نلاقيها في العيان. فيبقى الثريشولد البايوبسي يقل، لكن برضه بنحسب الكوست بنفيت لان ده انفيزيف مانوفر. واذا كنت شايف في العيان بالكوموربيديتيز والاسوسيشن ان انا مش هديله ايمون سبريشن ولا هديله تريتمنت، انا ممكن ما اعملش بايوبسي. لكن الريجيديتي ان مايند ان ما اعملش بايوبسي should be reduced. يعني threshold of doing biopsy in a diabetic patient should be lowered. ده الايه ده التشينج اللي حصل في اور مايند. دكتوره دولت عاوزه تتكلم، اتفضلي يا دكتوره دولت.
عندي بس استفسار. ثانك يو فيري ماتش يا دكتور حسين، انت يعني لخصت الانديكيشنز اللي هنعمل بيها البيوبسي في عيان الدايابيتس. انا بتكلم على الانترستيشن ليجن اللي قلتي عليها يا وسام. اولا diabetics are very liable to get interstitial lesions. عم كلهم بياخدوا non steroidals وممكن تجيب لي acute kidney injury و that sort of thing. يعني انت قلت انها بتبقى eosinophils والاكيوت interstitial nephritis بتبقى mainly lymphocytes. هل انت هتقدري تفسري لنا differentiate between this and that؟ لان لو acute interstitial nephritis انا لازم اتدخل واعالج. how can you really differentiate؟ انت بتقولي لا دي ممكن حاجه نلاقيها مع الدايابيتكس.
هي المشكله في presence of eosinophils not the interstitial nephritis. If you have an acute interstitial nephritis بتبقى apparent، يعني بيبقى diffuse predominant lesion present in the kidney
مع إديمة واضحة،
بتبقى واضحه سهله. هي المشكله ان الايزينوفيلز زي ما ان شاء الله يعني لو ربنا ادانا عمري we're going to discuss في التيوبلو interstitial disease ان دايما ال presence of eosinophils is related to drug induced injury. فهي دي الفكره ان ال diabetics commonly have eosinophils in their interstitium, so they're not correlated with the drug induced injury. If you have a dominant lymphocytic لا هعرف لان مفيش lymphocytic infiltrate. مش شويه الايزينوفيلز اللي هيبقوا موجودين دول او الاجريجيتس اللي موجوده هي دي اللي I'm going to interpret it. يعني حضرتك لو بصيتي على ريبورتس تلاقي الريبورتس كتير مكتوب diabetic glomerular sclerosis acute tubular interstitial nephritis with eosinophils. No, it's not.
اوكي لازم تبقى lymphocytes.
This is a common finding. لا بصرف النظر lymphocytes معاهم eosinophils or not، الموضوع ما بيتقاس كده، بيتقاس بالاكستنت of the injury اللي موجود. و I agree with you طبعا a lot of diabetics بياخدوا non steroidals و a lot of diabetics اكتر commonest injury معاهم is AKI. بس الحقيقه the commonest finding we find ان ال non steroidals بتعملها في الدايابيتكس is a tubular injury rather than a full blown interstitial nephritis.
هنا في سؤال على الميكروسكوب هيماتوريا امتى نعمل بايوبسي. انا زي ما قلت الميكروسكوب هيماتوريا مش ستريت فورورد انديكيشن فور دوينج بايوبسي، لكن لو معاها رابيد رايز اوف كرياتين او فيها كيدني امبيرمنت او فيها اذر ستيجماتا اوف سيستميك ديزيز انا هعمل بايوبسي. لكن سوللي يعني اونلي مايكروسكوب هيماتوريا دي مش كلاسيك انديكيشن ناو دايز، لانه في 50% من الدايابيتكس عندهم مايكروسكوب هيماتوريا. لا المايكرو البومينوريا اللي احنا ما عدناش بنحبها بنقول A2، لا المايكرو البومينوريا ولا الميكروسكوب هيماتوريا are straight indication for doing a biopsy. دكتور ياسر إدريس من السودان. الظاهر ان عنده مشكلة في المايك. دكتور هاني منصور. هاني.
دكتور حسين.
ايوه ليك سؤال؟
لا يا فندم محاضرة ممتازة.
الله يخليك شكرا.
دكتور هاني قاعد في السعودية يعني ادعي لنا يا دكتور هاني.
ربنا دكتور حسين ربنا ان شاء الله.
المحبسين اكتر مننا.
يا رب يكرمنا وكل سنة وانتم كلكم طيبين. يعني رمضان على الابواب.
سنة وانتم طيبين، رمضان كريم ان شاء الله.
وعندنا بكره وجبة دسمة مع الدكتور القوسي. هنسمع منه الكلينيكال ترايلز بالدايركت انتي فايرال اجينست كوفيد ان شاء الله بكره. في نهايه الحلقه النهارده بشكر الدكتوره وسام بكل كلمات الشكر. يعني مش هنوفي الدكتوره وسام حقها، وان شاء الله نتقابل على خير، وان شاء الله مكملين مع الدكتوره وسام في رمضان، بس هنبقى نعلن عن اول يوم ان شاء الله بعد الاتفاق مع الدكتوره وسام. اشكركم جميعا وتصبحوا على خير. مع الف سلامه.